We're going to get started here very, very shortly. I'm Carl Fuhrman from the University of Pittsburgh and Sravanthi Reddy from the University of Southern California. We're going to be the moderators. Our session is going to be on self-preservation skills for radiology educators. And our first speaker will be Dr. David Naeger from UCSF. I wanted to point out that David will be planning next year's AMSR meeting agenda for us. And I'm sure he'd be appreciative of any help or any suggestions anybody might have to make next year's meeting as good as this year's meeting. So, thank you.
Great, thank you very much. So this first one here is about getting recognized for your contributions. And so I was thinking about this, and I was afraid that people would maybe say there's no reason to have this talk. And I thought maybe the arguments would be in two camps. I was wondering if there might be some people, particularly if they're sort of new, who might say, isn't this sort of obvious? If you want recognition, you just teach, and then you do it well, you get good scores, and then you are recognized. Does this sound like how the world works to anybody? Yes, this is not academic medicine, so that's why we have a talk on it. Two, I was wondering if people might have a problem with this and say, is this a misguided talk? In other words, recognition is about the educator, right? It's about us. It's not about the students or the educational mission. So that's not great. And when we do actually talk about us, which is actually the point of this meeting, we talk about things about like health and sleep and eating and mindfulness and positive interactions, not recognition, right? But the thing is, that is the theme of this meeting, and it's actually the theme of this section. It's called self-preservation skills. So how is it that recognition at work can somehow lead to self-preservation? So how I thought about this, I sort of reflected on what is it that makes us happy at work, right? What keeps us motivated so we keep working? So you think the answer is what makes us motivated? Dollars, right? Or if you're in San Francisco, Bitcoin. And of course, I'm joking, we're the land of startups. If you want to be happy there as a worker, all you need is wheatgrass smoothies and a ping pong table. Okay, just joking. So money, ping pong tables, and smoothies don't do it. It turns out neither do things like just promotions, awards, and titles, right? What is it that makes people happy at work? There's a lot of things that have been written about this, but I thought to use the lens of the book Drive, which is written by Daniel. Ooh, this is very exciting.
Sorry.
We're losing cabin pressure. The oxygen masks are coming down at any moment. It's okay, I'm just going to keep going. So, the book Drive, what motivates us at work? Lots of things written about this, but in this one book, he specifically mentioned three things. And they are people love to have autonomy. This is, in fact, entire blogs that are written about how important it is for people to have autonomy at work. The next one is mastery, where they feel that they have control and knowledge of their subject. The third is that they're doing this work for a purpose. They believe the goals. So those are the three. What's not explicit in these three is a sort of social, the interactive part between people. So I'm going to add that, which is the appreciation and sense of respect, right? This is actually where the money and awards may or may not come in. But actually having positive connections where you feel you're respected matters too. So these are the things that motivate people at work. So that should be the goal of getting recognized. How do we maximize our autonomy, purpose, mastery, and a sense of appreciation? Okay? And that is my message. This is the point of the opening talk. Trying to get recognized at work can actually make you a happier worker and more motivated. So how do we do it, since it just doesn't happen on its own? I thought I would review this in sort of three levels of suggestions I have. The very first one, which you might not like to hear, is the recommendation to publish. Now, I know people don't like this because most of us in the room are not really into chopping up mice brains and gel electrophoresis and boring things like this. But it's publishing on the things we do work on the educational mission, okay? So why do we think we should do this? When you publish, you build up your sense of mastery, okay? Like literally 2 sessions ago, I heard someone say, oh, you've published on this to another person. I'd like to ask you a question. You feel ownership once you've reviewed the literature and added to it. In addition, there's some downstream effects. If this helps in being promoted, sometimes promotion can give a sense of being appreciated. And if it helps you get roles, which we'll talk about a little bit later, that can help build your autonomy. Okay. So if you're new to education, how do you build up publishing in education? The number one tip is mentors. Find somebody who can publish in education. There's some at your home institution. AUR actually has a mentoring program where you can specifically ask for someone to talk about that topic. Or find people at meetings like this one and talk to them. It also turns out this is great timing because there was a venture grant between AMSR and ACER talking about scholarship in education. It is halfway through now, so the first 5 are going to be posted, and there's still about 5 more to go. If you haven't seen them, you should check them out. Whoops. Now this, of course, you can go to the extreme. Most educators don't. Publishing helps. Getting grants is even more. There are some good education grants from RSNA, but this is a lot of work. Most of us don't go to this level. All right, level 2 is to lecture. And by lecturing, I don't mean teaching. I mean talking about the educational mission that you work on every day. So what do I mean by this? I mean presenting to your department and tell them what's going on in education. Maybe even giving a grand rounds in your department. Giving some talk outside your department, like to other educators or grand rounds in a different department. And of course, also giving talks nationally. So why do I think lecturing is good for getting recognized and making us happier at work? Again, it adds to mastery, okay? But here's the new layer. By going out and interacting with people who are sitting down, who come up after or asking questions, it builds a social aspect. It builds up the sense that people appreciate the work you've done and respect. Okay? And again, if it helps you get roles, maybe autonomy too. All right, so why did I talk about lecturing after publishing? The first is because it adds an extra layer, right? There's this now social part on top of the mastery. It's more interactive. And 2, publishing helps you get lecture invites, right? They see that you've done something in the area, then that helps. All right, so if you're trying to get into lecturing about this, what are some tips? Publishing is the first one, because then people recognize you, okay? The next one is just to get involved in societies. So here at this meeting, there's an ACER and AMSR business meeting coming up. There's an ACER-AMSR combo open house or social event in 2 days. So these are places where you can sign up for committees and get involved. That helps with getting invites. Okay. All right, and then the last layer for getting recognition is looking for or accepting roles and new responsibilities. So what do I mean by this? Committees that are focused on education, maybe leading the committees. Applying for specific jobs where you are a director of something, you have funded time to do something in the school. Being a course director inside or outside your department. Or being the director of a certain thing, residency education, med student, whatever your thing is. All right, so why should we be going for this level? Again, a sense of mastery. Okay, but here's the 2 new things. Now that you have roles, this is what gives you a sense of autonomy. You now can affect the educational mission, see how it turns out, make decisions, find out if it works. This is what brings happiness to people, to having some control. And this is where it shows up. The last thing that it does is to add some purpose. So I want to talk about purpose for a second. Because as an educator, we actually have lots of purpose, right? In just everyday teaching, I think purpose is pretty easy, right? We have a connection with students, we teach them something, you can get the feedback. As a side note, in this teaching picture, I have no idea what's happening. They're out in the woods, there's fog, there's a poster board, I don't really know. But it's clearly teaching. So purpose is here. Interestingly, there's not as much sense of purpose in the publishing and the lecturing. I mean, there should be, right? You're teaching people about your programs and about teaching, but it just doesn't have that same purpose that you get from one-on-one interactions with students. Lecturing just does not do it. But it does come back when you start doing committee work or you have organizational role. Because when you're working on the educational mission as a team, it brings back that purpose. You teach, and you're facilitating other people to teach. The purpose comes back. All right, I do have some caveats though, okay? So this part where we do the roles, there are some risks. So here they are. Caveat 1, once you start getting roles, it doesn't stop, right? And then all of a sudden you have a million things to do in no time. So the classic teaching is you have to learn to say no and just drop things. But this is, of course, really hard, right? Who's good at this? Nobody. That's how we got here. So my suggestion is sort of the opposite, especially if you're new, which is when you don't have a lot of roles, proactively go out and seek the ones you do actually want, right? And then become totally full with the programs that have the most purpose and the most interest. Then when you're full, people stop asking you because they're like, oh, that person's busy. And it's really easy to be like, oh yeah, I'm working all this stuff. I can't really do that. It's much easier to say no. Caveat 2, I said purpose, but you might have ever been on a committee once where you've noticed there wasn't much purpose. I was on a committee once where its only job was to go over the wording in policies. It sounded good at first, but not great on purpose. Are you okay? Okay, yes. All right, caveat, I thought she was choking. Okay, caveat 3. This is not a layer where we do it to get respect and appreciation, right? You do lots of committee work and really it's just the problems come to you. This is not where people are like, thanks so much for all the hard work. But that's okay. That comes in with the lecturing, with the teaching, and with the publishing. This part we're not doing for this. We're doing it for autonomy and some purpose. All right, and then the last caveat is this one. We actually have very compartmentalized lives. Like right here, we're all at a meeting, but we also have our own life back at our institution. And in fact, our department is also compartmentalized from the school. So if you are trying to get autonomy and some sense of purpose in one by having some roles, but then you go back to some other place and you don't have them, it doesn't translate. So you have to sort of build up some responsibilities in all of these areas to have that sense of purpose and autonomy. Okay. All right, so that was the end of my warnings. They've pulled in lots of money with this. So some final tips for succeeding with roles, committees, etc. Once you are given roles, you want to do a good job. Okay? So be very responsive, available, do everything fully. If possible, find out what other people think are the problems, right? If you're responsive to other people's senses of problems, then you can solve them with your roles. That will increase the chance of success. Don't forget to be an advocate for radiology, for your department, for your university. Wherever you go, you're trying to represent the mission that you are supporting. And then finally, serve the purpose. That's why we're doing this anyway. So if you are making sure you are serving your learners, things will be okay. All right, so again, we're talking about recognition, and the whole point is to increase these things that will make us happy at work. And if we do that, then recognition can directly make us happier and more productive. All right, that is it. Thank you very much.
Thank you very much, David. We're going to hold questions to the end of the session. Our next speaker is Alex Grieco from Ohio State. And coaching students through the career application process. Thank you.
Good afternoon, all. Thank you very much for being here, and thank you, Carl and Sravanthi. As Carl mentioned, I'm going to be talking about coaching students through the career application process. Absolutely nothing exciting, unfortunately, to disclose. When we think about this, coaching students through the career application process, I really like the fact that Dr. Anya Kelly placed it during survival skills, because if we really think about this in a holistic sense, We are doing that to help ourselves here. And when we view that process, it can seem a little infinite. And one of the things we have to keep in mind is that as we help our students get through the process, there's a big cast of characters for us to think about here. And I invite you to think about this with me so that at the end of the session, we can describe the context for coaching students through the application process. Discuss 3 areas of focus for optimizing the coaching that you're already doing, and name one strategy that you may be able to use in the upcoming 2018 to 2019 application cycle. So a little background first. Now, career advising and coaching medical students, that is not new for AMSR and AUR in general. We all have undoubtedly taken part in that directly or indirectly as we go, and so we are aware of many excellent resources that are in existence. We have the AAMC, the Careers in Medicine site, this I'll plug again a little bit later. We certainly have the NRMP, the match data and documents available from that site that we can also talk about. The AMSR guide to applying for radiology residency, both the IR and the DR version, of which several of the authors join us today. And of course, the Team Rad's Apps of Steel by my mentor, Dr. Magid, who the editor-in-chief joins us in the audience today. Many different sources that we're already using and aware of. So thinking about this for a second, that coaching for residency apps is not equal to coaching through 4th year. Career planning and application, of course, that's a 4-year process. And similar as Dave mentioned, there are some caveats to this. What we need to keep in mind as medical student coaches, you may be coming onto the scene or be asked to help very late in that process. Also, the students you coach may not view the process as a 4-year story. So our plan today, how can we really navigate this? I want to review the context for coaching of students and 3 areas of focus that we should certainly focus on. Number 1, connection with your Office of Student Affairs. 2, strategy for app preparation, both in place and in time during the cycle. And 3, coaching and advising by the numbers. Again, parts of this are going to reflect what we're doing first. If Carl and Sravanthi called me this morning and said, Alex, you got 2 minutes, break it down, the one thing I would talk about is right here. The most critical element of the entire coaching process, stay connected with your Student Affairs office, because the style, timing, and direction of residency advising by the dean's staff really is going to vary by institution, and we want to be in sync with that. I'm going to look at that interface, meaning, is it mainly centralized in terms of advising with specialty department designees for select areas? Is it mainly referred or deferred to the specialty departments? And where are the check-ins along the way? Well, again, we can think about the different roles. We have the characters in our specialty. And for thinking radiology career advisor, clerkship or elective director, the RIG advisor, letter of rec writer, research and scholarship mentor, you might be thinking, gosh, I do all of those things. That might be one single person. And when we think about that in the department, the key interface is the IR and DR program director. How in sync are we there? Several who work with students have served in the PD role, never more important than our current time, as I'll get to later. Cutting back to student affairs, there's going to be, whether we're talking about DR, IR, surgery, anything, there certainly are institution-specific elements. The MSPE, Medical Student Performance Evaluation, the timing and content there are going to vary by institution and how much we can contribute. The NRMP guidelines, believe me, those are revised and constantly looked at. Those are going to be coming to the Student Affairs office. For example, there's been a lot of talk recently about just how much we are allowed to talk with students about the rank order list. And then the directive to go on is with your Student Affairs Dean says. The school-specific requirements, yes, you've hit all the EROS and the NRMP deadlines. Did they get Step 2 scheduled? Do they have their away rotations approved? All of that has to be looked at closely. And then I just throw it out there. Is there a curricular career thread? Is there time, is there space in that curriculum that they've been to where they have dedicated time to think about radiology or any career? And do you have a designated career counselor? Back at the Ohio State University College of Medicine, I serve as our career counselor, so basically kind of the co-pilot for our Dean of Students, connecting student affairs to the specialty departments. And I work with pretty much every one of the students in all 4 years at one time or another to be able to do that. If you have somebody like that at your institution, that's somebody to become very familiar with, because each step of the process can be bolstered by working with that person. So back again to student affairs. The best practices for that interface, well, it's less defined than with curriculum and clinical expectations. Exemplars exist, but again, that's going to be institution specific. Here's the ideal model. Regular communicate with your dean of student affairs, your career counselor. Set up a plan for central versus specialty specific elements of advising with the ability to confer with the positive and not so positive issues that arise. 2, our second area of focus, strategy for app prep place and time, the most commonly cited element of career application process likely. It's a motivating factor, that calendar, the stress factor, the to-do list factor, all of this we need to keep in mind. There's a lot to do. There's many things to take in when you have a specific date in mind. And when you take it up to this, we can break it down accordingly. This is a little snippet of our calendar that went out to our now fourth-year students. Many of us have something very like this that we might distribute or use with our students. We have this, ERAS submitted September 15th, rank order list, the match day, everything here. So my question for you is, what's missing? It's great, right? We give these out to the fourth years. What's missing exactly? When do meetings take place? How long does each thing take to do? And when you work with students, one of the first things you want to do is break that down. Let's look at the ERAS submitted. Great. Well, when you're going to strike that hammer and submit your ERAS application, I tend to view it and work with students like this. CV, that's got to be early May. And we can all remember doing that ERAS application, the single best thing you can do is to have an up-to-date CV. Personal statement here, certainly a big amount of time, not just for the writing, but for the invariable feedback sessions. ERAS app proper, the different parts of that is certainly going to be here, the MSPE meetings to prepare for, and we have all been in the boat of having to wait it out and sweat it out with our students till 11:59 on September 14th for the letters of recommendation to get uploaded. And if we look at these, the factors are going to break down like this. The due dates for each element, that's fine. We need to think about the time for completing that and receiving meaningful feedback in concert. When to be able to say, not now, in progress. That's another little interesting part of this. We have to know when to get things done, how much time to do, and you actually have to do a little coaching, I would argue, more so on the, we're not going to have the answer to that right now. I can't tell you exactly right here. That's all that we're going to be able to do with your personal statement. We need to let it sit for a minute. And that dealing with the unknown is a very new concept for a lot of the medical students that we've already worked with, undoubtedly. And we got to keep this in mind. This should be on the app calendar, but hardly ever is. That for these incredibly qualified, high-performing learners, this process might be the very first developmental crisis that they've ever had. Think about it, okay? When have they been in this situation before? So much unknown. We've all been there. We need to be able to step in. Check-ins on wellness. I had these added to our calendar. Self-care assessment, thinking of ourselves and our students together, because all of that's going to be in that decision-making capacity to make sure that that shield stays strong. So finally, coaching and advising by the numbers, not a surprise for this group. Think about it. Career app advising, and like all of medical education, of course it's going to be data-driven. We have sources for that. We're quick to say, look at the data, right? What does the data say? It's a very blanket term. And as with everything else, we need to be able to look not just at the data, but about what it informs us to do. It's constantly updating. The implications are constantly updating. And I would make one more plug in that regard for the AAMC Careers in Medicine site. This link here, very findable on that site. They're expanding, actually, the residency and fellowship information session about applicant qualifications that anybody can access free of charge. Now, of all the pieces of data that are sought after, that must be handled with care, and be careful whose hands they fall into, so to speak, the NRMP data. Now we have two versions of this. The results and data of the match are available every year, and have those already for 2018 are posted. Charting outcomes is the research document where the data comes out by applicant qualification, and that's where a lot of our coaching has to be centered. We'll be due in 2018. They're aiming for July or so to get that document. That's going to be just in time for advising our students about the application, launch, the number, the place, etc. So here we are. Here's 2016. You can find this 2 clicks, and here we are. Check it out. Not bad, basically. Looking at this chart, match rates of U.S. allopathic seniors preferred specialty, meaning if you wanted to do diagnostic radiology, there you were, 98%. Okay, so pretty good. This is reassuring and the students can come away and say, well, I've read the data. I can do radiology if I want to. Okay, well, this was 2016, remember. Just came back a week ago in Orlando from the AMC Student Affairs meeting and got to hear from somebody named Dr. Mona Signer, if that name rings a bell or a little faint of heart moment for anybody, the CEO of the match. And basically, she stopped her talk to say, oh, now I need to stop here. She's basically presenting this, the first page of the 18 data. I need to point out something to you. When she talks about your field, you sit up straight in the chair. She pointed out and said, radiology diagnostic offered 125 CAT positions, 944 all categorical positions, 100%, 99.5% advanced were filled, both among the highest on record. And then her nice little greeting here. So she basically said, start talking to your students now, that chart about if I wanted to do radiology, will I be able to? That's gonna fall. And we need to be able to and be in a position, as we're recovering from a few years ago when we had a little different view of that point, we need to keep in sync up here where we are going to be the highest on record. So in this whole process, I think we've looked at some heroes, some different characters here. Who's the villain that we need to confront? Is it massive app numbers? Is it stress? Is it the unknown? Actually, I'd say this is the biggest villain that we need to be very, very careful of as we work with our students is conflicting information. And that's why we need alignment between advisors and those different levels of communication with students, the most critical related to the match data. Beware of the good cop, right? We're prone to that after a little lull in our app. Say, of course, go for it. Low ball app number, yes, of course you're going to be competitive. We couldn't give away spots 6 years ago or something to that effect. Actually overheard one where somebody was saying to back up in interventional radiology. And we stepped in. Be okay with being the bad cop. Okay, somebody attend to Kimmy back there. No, so the whole idea is, my question for you as we draw closer, is there any additional data that we need to contend with? Student-coach connection. Okay, we spent this time talking about all the features that lead to something good. There's an unintended side effect here of the better longer-term coaching relationship. That student might be less likely to bring up something negative in their application, whether it's USMLE, professionalism, a fourth-year rotation issue. The idea is you don't have to coach and solve the issue or its appearance on that MSPE as a coach to the student. You do have to help the student develop and apply emotional intelligence to stay the course. So we recapped, thinking about this. We coach students through the career app process in context. It's 4 years with variable timing of our connection. The 3 areas of focus for optimizing your approach to career coaching, connecting with student affairs, strategizing for apps in place and in time, and of course, coaching by the numbers. Think about what might be useful to use for your 2018-29 season. I want to thank everybody once again for being here, and I would love to hear from anyone with more questions later. Thank you.
Okay, so thank you very much for that great talk. The next speaker is going to be Jeanine Beatty-Chadha, and she is going to talk about engaging medical students.
Okay, thank you so much for welcoming me to this talk. My name is Jeanine Beatty-Chadha, and I work at Penn State. And my background is actually in education, and I serve as curriculum and educational development specialist, working with the Department of Radiology, offering workshops monthly on educational topics, and working alongside educators in the department, developing curriculum and other things. And I also serve as co-director for the Students as Educators elective for fourth-year medical students learning how to teach. So I know, just as far as thinking about self-preservation, I know that I always encourage people to think about how much you can learn from your learners. And I know that I'm learning from my learners all the time in the Department of Radiology. So just a little overview of my time with you today. First, I want to talk a little bit about effective educators, some of the characteristics of effective educators. Then talk about engaging medical students and as a resident educator, and at the end, I want to invite you to share your thoughts and questions. As my colleagues at Penn State know, I like to have a lot of interaction in my talks. I couldn't help myself, but try to work a little bit into this 15 minutes. So at the end, hopefully we'll have a little bit of time for you to ask some questions or share some ways that you engage medical students. So first thing I'd like to do is to ask you to pause and think about this question. How would you describe the best teacher that you ever had? And that can be from any time in your educational experience, early on, high school, college, medical school now, or even a colleague that you work with. So think about who those people are. I've had this conversation with people in a variety of settings, teachers becoming elementary school teachers, those medical students who are learning how to teach while working with first or second year medical students, and a lot of common themes come up. And we know that there's been research on this topic and a nice lit review that I'll share with you. And some of these themes might have been what you came up with as you thought about the question. Our best teachers are knowledgeable and skilled, so you might just be in awe of what they know and how they do it. They're supportive and they're effective communicators. They're enthusiastic about a topic. I know there are a lot of people that I've worked with who I might not be that interested in what they're talking about, but once I work with them, I get it. I understand why that might be something that you want to learn about. And when I work with the medical students and students as educators, a lot of them talk about really what it comes down to is that the educators that they worked with that were the best really care about them. They care that they're there. They show an interest in teaching, and they just want to be there. And we know this in a variety of literature across medical education, that even when we're thinking about feedback, for example, there are authors, Telio et al., talk about the Educational Alliance, and they give a little bit of background about feedback and how we know that if a learner doesn't see you as a credible, reliable ally, they're less likely to use that feedback to make some changes later. So we want to put in the foreground the importance of that relationship and not just think about what we would tell learners to do as a result of our observations. So rather than just think of the common approach where we provide suggestions and expect learners to use that feedback to improve, we want to think about that trusting relationship and think about negotiating some goals, our shared understanding of the goals, and then agree on how we would use that feedback in practice. So what I ask for you when I think about some common suggestions that I would make for you as an educator, I want to frame it by really bringing that caring aspect to the forefront. So I was thinking about this, and I decided to kind of organize the talk according to these 4 different themes. So as you're working with medical students or you're teaching your residents to work with medical students, ask them to think about this care model, that you will connect with learners, assess, role model, and evaluate. So connecting, making sure that you listen and connect personally to them, that you make connections to their future goals. There were some great talks that have already happened about really thinking about how most of the learners that you have won't be going into radiology, so thinking about how you can make connections, and then just simply showing an interest in teaching and connecting with them in that way. We know that we need to assess our learners. We need to gather some information about what the learner knows, then teach, and then assess whether or not they've met those goals. And we also need to engage in feedback conversations in an ongoing way. So rather than just give that feedback, when we're working on building a trusting relationship, making sure that you start those feedback conversations using an ask-tell-ask model, where you ask the learner to reflect on what they already know or what they're learning about how things are going, and then you share your observations with them. It opens up the conversation naturally. They might already bring up some things that you observed as well, and you don't feel like you're on the spot in pointing it out if they've had some difficulty. And then ask for them to start to determine some next steps. Next, I would suggest that you really stress the importance of role modeling, because according to that Educational Alliance and what we know about feedback, learners are more likely to accept feedback from someone they view as a credible ally. So making sure that you're demonstrating what you expect of the learners as well. So one thing that I would suggest as a kind of a teaching tip is the value of think aloud in role modeling. So in a think aloud, this is where an educator simply verbalizes how to use available information to generate a solution. It's not your explanation of how you got to that point. It's just showing a learner how you go through the process of working out a problem. And this is really valuable to new learners because they don't have access to that information. They don't know how you get to that answer. So making sure that you're really thinking through the problem for the learner so that they can really see how that works. Now, we're talking about engaging medical students, and that sounds like a really passive way to teach, that you're just talking and they're sitting back there. But it really has to do with how you frame the think aloud and how you frame anything, really. A lot of times they're just thinking about how you set things up. If you ask tough questions, explain to them that the reason you're doing that is because it's important that they're able to do that later. So really setting things up. So when you have a think aloud, just framing it by beforehand telling them that you'll revisit the information later. So before you go through and share your thinking, tell them that after you're done, you're going to ask them to describe what you did. You might ask them to prepare 2 questions to discuss afterward, or you might even ask them to observe another person and then compare and contrast what they saw for both of you performing the same task. So then, at the end, we want to make sure that we're evaluating learners. So with all this ongoing engagement and feedback, evaluation is simplified. Hopefully you've taken some notes along the way, that you have some information to give them, very specific, concrete information. We want to avoid that read more kind of feedback, something specific for them to work on. And nothing should be new to the learner. So a lot of these things are things that we hear about often. But we also want to think about evaluating your own teaching. So there are oftentimes feedback mechanisms in place, but if not, simply giving them a sheet of paper where they could write down what went well, what you need to work on. This is how you will improve your teaching. And I urge you not to be afraid to try something new. Some things won't work, but you can go on doing things that are kind of okay and, do okay with it. But if you try something a little different, that's how you can really grow. So making sure you're doing that and getting feedback from learners. So again, just really thinking about building that relationship to engage learners and really engage yourself too in making things more interesting as you connect on a more personal level. So now I'd like to ask you to share how you engage your learners. We have a few minutes to do that. And I've actually developed a Google Doc. If some of you, I've seen some computers out there, if people want to start to jot down some notes. I didn't fill it out too much, but I can go back and add some of the information from my slides to kind of serve as a resource for you to go back to later. So would anybody like to share some of the things that you do to engage medical students? Or ask a question, either one? And my Penn State colleagues know that I have good wait time.
One thing is just to, when they appear, say, oh, come over here, and let me show you this case. You kind of roll out the welcome mat, and that breaks the ice.
So really coming back to just showing an interest and not just letting them stand and not know where to go.
One thing that I do when I'm teaching students, particularly one-on-one, is I'll be teaching in a class of 150 students that I don't know, so I'll introduce myself. I'll tell them where I'm from and where I went to school, and I'll ask them the same questions. Maybe in a group of 4 or 5 that we work together, and it kind of breaks the ice, and that way I can also know a little bit about them and remember their name a little better. So when I see them walking through the hospital and they say hey to me, I'll know who they are.
Right.
But I just try to engage them on a personal level as a prelude to teaching.
Right.
Something that I do on a one-on-one, at the workstation, for instance, I have them look at some studies while I'm working on other things. I have them preview studies and then go over them afterwards. So then they're not just watching me dictate.
Great, great. And I know that there was a great session today about teaching methods that you shared, so some other ideas too.
I'm a big fan of RAD-PAT. So if I'm the body imager, so if I do a biopsy, I'll have the student watch me, and then we'll talk with the cytopathologist and we're going to the microscope together and try to come up with a differential before we do it, and then see if we're right.
I know from our experience last year, one of my students as educators, medical students, was actually going into radiology. He'll be a first-year radiology resident at Hofstra next year. His name's Ritesh Patel. he did one of our sessions for the work that I do with radiology and talked to medical students and faculty about engaging med students, and found that they really enjoyed modules and cases. So when things get really busy, this is something that you probably already do. If you have modules, you can have them go and look at that, or giving them cases that you can then review later to help engage them and give them a real world task. So, any questions or other things that you want to bring up? Okay, so I wanted to thank you, and if you want to contact me about anything, my email's up there. And I also want to thank my colleagues at Penn State and how much I learned from them all the time about teaching and learning. So thank you.
Thank you. That was very interesting and useful. Our next speaker is going to be Leslie Scoutt from Yale, sorry. And she's going to be talking about the approach to faculty, colleague, resident, and medical student in distress.
So I sort of apologize for ending a little bit on a downer, but this is after all these great lectures, but I wasn't the one that designed the rotations of the lectures. So I am an educational consultant for Philips Healthcare, but it will not be relevant to this presentation. And what I hope to do is to define the problem, talk about how to recognize it, focus on intervention and remediation, and end up with documentation and what we can do to prevent this problem from happening. What we're all trying to do for all levels of trainees, of course, is to help people develop expertise. And research has demonstrated that expertise is actually probably best learned through intentional practice above one's comfort zone and competence under the guidance of a coach who can provide feedback and teach self-reflection. And for any of you that started your internship in the ICU, you know exactly what I'm talking about. The problem is that in today's practice, millennials do not like to be out of their comfort zone. In addition, lots of institutions no longer allow people to practice with any independence above the level of their competence, and the coaches, namely us, have much less time than we used to have, and maybe actually haven't been taught the expertise to provide effective feedback and to teach learners self-reflection. So the end result is, if you excuse, please, a little political comment, is that we're dealing with a perfect storm, for those of you who watched Saturday Night Live last weekend. Anyways, so undoubtedly, all of us are going to run into a colleague or a trainee in trouble. And this has been defined as a trainee who demonstrates problem behavior serious enough to require intervention by program leadership. No specialty is immune. This issue affects all levels of training, including medical students, residents, as faculty. It's a very common problem, particularly among residents. It's estimated that some sort of distress occurs in about 5 to 15% of all residents. And there's been, in fact, very little research on this topic in terms of epidemiology, as well as effectiveness of remediation and intervention. And in addition, the research that has been done is extremely limited by reporting bias and lack of consistent definitions. The end result, though, is that trainees in distress generate disproportionate amount of work for program directors as well as colleagues on all levels, and can be generally demoralizing, of course, to the program. So it's important to recognize and to develop means of early intervention. The problem with recognition is that very few individuals self-report. It's estimated that less than 2 to 6% of people come to recognition through self-reporting. Most individuals are reported by attendings, and that is followed by chief residents. So chief residents have a very important role in recognizing colleagues in distress. But people also come to attention through referrals from peers, ancillary staff, particularly nurses, and occasionally from patient complaints, and least of all from adverse events. What can you do to recognize a colleague in distress or a trainee in distress? Well, poor performance is probably the easiest thing to recognize. This is poor exam performance or a poor performance on other types of assessment. Poor conference attendance is a red flag, and very often when you meet with trainees to give feedback, they are really remarkable for the lack of insight that a struggling individual will have regarding the problems that they might be facing. You have individuals who are late to work, who call in sick, who leave early, have obvious signs of depression, lack of engagement, fatigue, lack of focus, reported to not finish assignments, and increasingly you have individuals where they have excessive cell phone use or surfing the internet when they're supposed to be paying attention to what they are doing. Another thing is behavior issues, constant complaining. And then, of course, there's more disruptive behavior patterns, inappropriate behavior in front of patients, poor inter-team communication, which is really a euphemism for rudeness or lack of respect for people on the healthcare team. It can go as far as anger or actually outbursts, and again, individuals who do not fulfill their responsibilities are considered to be lazy, get other people to do their work. All of these things are red flags that can bring people to attention. And when you have a person who is identified as being in distress or having a problem, and you decide that you need to make an intervention or to direct remediation, the first step is in the identification of the underlying problem. And generally speaking, these problems fall into one of three categories, namely personal issues, which could be mental health or personal stressors, a knowledge deficit, or professionalism. And while you have those three buckets, the thing to remember is that often that these are multifactorial and often they all interconnect, and it's like dominoes. One thing can trigger a problem in multiple different levels. It's interesting that the likelihood of a particular problem, research has shown, is really quite variable dependent upon the level of training. So in general, medical students tend to present more commonly with mental health issues, whereas residents present more commonly with medical knowledge deficits. And professionalism, the incidence of that increases as the level of training increases. So professionalism issues are more common actually among attendings than they are among junior trainees. Well, the first thing that you ought to do, trying to get down to specifics, most people recommend is the so-called cup of coffee conversation. And this means sitting down in a non-confrontational way with the individual to talk about the issue at hand. This avoids doing something formal initially. It allows you to get the individual to perhaps identify personal stressors. And you begin this by saying, without even bringing up what the issue is, are there issues that you're having at work, problems that you can self-identify at work? Is there anything going on at home? And this is an opportunity for the person to identify stresses that they have before you actually start getting down to the details and talking about the problem. Once you do that, you then can solicit the individual's perception, ask them perhaps for an explanation, give them the opportunity to reflect and to be responsive. You can ask them, what do you think you could do to improve things? And then, of course, you want to end up with, what can I or what can others do to help you? Looking at the three buckets I talked about, the first one you want to pay attention to, I think, is mental or medical health issues. And again, the emphasis here is to be supportive and to see if you can identify any potential specific stressors. People talk about the 3 Ds: depression, divorce, distractions, drinking, and drugs. I would add to these work-life balance, as well as the issue perhaps related to money. And all of these things are things that you can address with the individual to see if they are impacting their life in a significant way. And if you identify these things, do not hesitate to refer the patient or the individual to professional help. It is not necessarily your job to make a diagnosis, to prescribe medication, but to identify a professional who can actually help them. Sometimes the issue, as we've heard already today, is going to be about career counseling. You know, maybe they have embarked on a path that's not feeling quite right to them, despite the fact they had excellent career counseling. Maybe now that they've started doing it, it's making them uncomfortable or anxious, and they need to find something different to do. And so I think that is an important thing as well. It's also very, very important to have frequent follow-up with individuals who are in distress. This is not a one-time intervention, but you need to demonstrate your support, your commitment, your interest in them by having frequent follow-up. And if an individual, in fact, does have mental or medical health issues, you may need to have a professional provide a fit-to-work clearance so that they can come back to work, and you should not be afraid to do that for the, basically, the protection of the individual as well as patients. In terms of people with performance, again, you want to start by being supportive, and you want a holistic approach. Remember, these other buckets may affect poor performance, so the very first thing, again, is to identify if there are any of those stressors that I mentioned already. Then you want to approach evaluation of time management, organizational skills, study skills, possibly even including an evaluation for potential learning disabilities. And again, this may be beyond your expertise, and you may need the help of an educational specialist. A very important thing to do is to assign a mentor, and this could be somebody specifically for teaching and remediation of specific knowledge defects, but could also be, or in addition, be a personal mentor who can help with study skills and some of the stressors that we talked about. You want to develop a focused, specific, stepwise learning plan, and you should review the available study aids in your department. Talk to residents who have been successful. Find out what worked for them. Talk to residents who failed and have been successfully remediated and find out what worked for them. And it may be different program to program, and it may be different individual to individual. So think about assigned specific reading assignments, item banks, some are better than others, but possibility of individual tutoring, encourage and, in fact, demand conference attendance, and don't underestimate the potential use of self-assessment modules. This is true at all levels. People like success. They like to have a test to identify what they've learned, and this helps them self-reflect and identify continued areas of weakness. And in extreme cases, you might need to consider repeating rotations or even extending training. Establish goals. Help the individual make time for studying. You may need to limit away electives, moonlighting, and even research in order to get them to focus on the problem at hand. And again, I want to emphasize the importance of frequent follow-up. Again, be supportive, assess for stressors, and with somebody who has issues with poor professionalism, but advise the individual very concretely about behavior that will not be tolerated. You will need to know the hospital bylaws to know what your institution will and won't tolerate. Be calm, be clear, even if the behavior seems just terrible to you. You have to be calm and clear as you talk about it, and the individual needs to know as well as acknowledge the consequence of continued poor behavior. Maybe you'll be lucky. Maybe this is a one-off. Maybe there is a single transient individual stressor that can be dealt with that resulted in poor behavior this one time. But if it's a pattern, the individual needs to know that the behavior won't be tolerated. And remember, in this situation, outside referrals are very important to psychiatry, psychology, anger management courses, and sometimes even drug testing. In terms of what is your best chance of success of remediation, if there is a specific and hopefully transient personal stressor, these are almost always, if they can be identified, can be remediated. If the issue is poor performance, there's about an 85% chance of successful remediation if you can identify the knowledge and learning skills deficiencies, even if these are learning disabilities. The most difficult thing to remediate, though, is poor professionalism. And so some tips for that are to focus on the importance of the professional behavior in terms of optimization of patient care, the importance of team building skills, the potential for advancement if these issues are taken care of, and as a last resort, you should talk about the consequences of continued bad behavior. So again, to reiterate, Important to assign a mentor, establish precise, detailed plan of action, measurable goals oriented to the specific problem. These should be achievable, reasonable, objective, and you should establish a timeline as well as identify the consequences of lack of compliance, and this should be documented. Routine and frequent follow-up with a mentor, be kind, supportive, accessible. You can adapt a plan that isn't working, but stick to the basic principles. And in terms of documentation, don't wait for failure. Document, document, document. But understand you need to be careful how you do it. Once you've documented, it becomes a part of the permanent record, and that has consequences. So you may not want to document officially until you're really certain that there's a real problem and you're concerned possibly about legal implications. And in that case, you may want to have a third party present. In terms of prevention, application materials, unfortunately, rarely help identify an individual at risk. But what can you do? Establish a supportive environment that medical colleagues can trust. Trainees should feel that you support them and want them to be successful. But remember, success is a very complicated term. It implies pressure, outside validation. You want them to do a good job. You want them to be an expert. But on the other hand, you really want them to be happy and to find the career that is most fulfilling for them. So again, mentorship, early intervention, and to get and achieve early intervention, you really need honest and timely feedback from people who evaluate these individuals. 360 degrees evaluations, very important. Reliable measures of success and self-assessment, very important. The individual needs to believe that there is total confidentiality, you need professional backup, and you should think about developing programs to help your faculty grow in terms of teachers as well as mentors. There is increasing emphasis on focus on well-being, things like exercise rooms, meditation, yoga, mindfulness training, providing time for wellness visits, departmental social activities. Encourage your trainees to focus on their well-being, ways of reducing stress, family, and fun. And I want to end as David began, and we really didn't communicate about this beforehand, but you should think about yourself and for your trainees. Advise them to think about what makes you happy. Thank you.